I welcome you all to the No Thrombosis National Workshop Program. Let me first introduce the faculty for today's session. We have Dr. N.R. Ichapuria, who is the Program Director. He's the Director Neurology, Sahyadri Hospital, Erwada. He has first started Neuro ICU and Neuro Intensive Care of Pune. He has been a pioneer in thrombolysis treatment for stroke in India. He has more than 300 public lectures delivered and workshop done on stroke. He has been a member of Indian Stroke Association and the organizing president of StrokeCon 2012 and also the organizing president of ISA Stroke School. He has been a founder of a Pune Stroke Program, ex-president of the Society of Neurosciences, Pune, Maharashtra Academy of Neurology. He has been PI for many multinational stroke trials like Perform, BrainsGate, BG12, Cortical Venous Thrombosis, Interact 2, etc. And he has been awarded as Health Icon by the Times of India Group. Welcome, sir. We have our first moderator for today's session, Dr. Nathaniel Sase. He's a professor and head of neurology unit GMC Meerut. He has finished his MD internal medicine from Shivaji University and DM neurology from Dr. MGR Medical University, Tamil Nadu. He has held different posts in Vanless Hospital, Meerut, and finally has been appointed as director of Vanless Hospital. In addition to his clinical role, he has also contributed to medical education. He has been a lecturer at Government Medical College, Meerut, and has served as postgraduate teacher and examiner in medicine at MUHS Nashik. Welcome, sir, for today's session.
Thank you.
We have our second moderator, Dr. Prasanna Kasegaonkar, who is the chairman and consultant neurologist, CNS Hospital, Solapur. Amongst his education, he has achieved gold medal in DM examination. He has around 5 years of teaching experience in the Department of Pediatrics at Dr. VM Medical College and CSM General Hospital, Solapur. He has a total 22 publication and paper presentation at national and international level. He has been member of various academy and association of neurology and physicians. He has been awarded several awards like Healthcare Professional of the Year 2017 Neurology, the Luminaries Award 2018, Dhanvantri Ratna Puraskar Award 2018, and Aadhar Maharashtra Bhushan Puraskar 2018. Welcome, sir.
Thank you.
We have our first speaker for today, Dr. Prakash Bhatt, who is a neurologist at Satyam Neurology Hospital, Bhavnagar, India. He has finished his bachelor degree medicine from MB Shah MRCP Neurology from London. He has worked in various hospitals like Sri Bajrangdas Bapa, Aryodhadham, Sahyadri Hospital, HCG Hospital, and Nazareth Hospital. He has successfully diagnosed and treated over 300 patients with complex neurological disorders, improving patient outcomes significantly, and has published research on neurological diseases in reputed medical journals, contributing to scientific community. Welcome, Dr. Prakash Bhatt.
Thank you.
We have our second speaker, Dr. Vinayak Jatale, who is a consultant and HOD, Seth Nandan Lal Dhuth Hospital, Aurangabad, Maharashtra. He has finished his education DM Neurology from AIMS, MD Medicine from MGM Medical College, Indore, and MBBS from LT Medical College, Mumbai. In his current institute, he has achieved many achievements, including but not limited to spearheading expansion and enhancement of neurology department, resulting in increased patient access and improved service delivery, and development and implementation of protocols for diagnosis and management of complex neurological conditions, etc. He has been involved in various research programs and studies, including but not limited to collaboration with Dr. Sudhir Kothari and IIT Institute, Indian Institute of Information and Technology for evaluation and monitoring assessment of vertigo patient, association with Dr. Apurva Poranik in aphasia group research, etc. Welcome, Dr. Vinayak Jatale, to this session.
Thank you, ma'am.
And now I would like to hand over to Dr. Ichapuria to please proceed.
Yeah, welcome to everyone. And welcome to Dr. Sase and Dr. Prasanna Kasegaonkar. It's a great pleasure to have you again on the show. And we have been doing this for the last 1.5 years. And I think it's been a great success. We think we have helped many people, and which I'm sure we have. And we have learned a lot in the bargain. In fact, the persons who present and the persons who are on the dais learn more than the onlookers. So at least I have learned a lot, and I'm sure Dr. Sase and Dr. Prasanna also have learned, as they have been moderators before. So we can now start with the first case. Who's going first?
Sir, I'm going to present.
Yeah, Prakash.
Yes,
Prakash,
sir.
you were in Sayadri, no?
Yes, sir. I was in Sayadri from 2007
Yeah,
to
yeah,
20
yeah,
under Dr. Devte and
yeah,
Dr.
yeah. I
Sant.
know you well. Yeah.
Yes,
So
sir.
it's
Yes,
good
sir.
to have
Thank
you
you.
on the show, and
Thank you, sir.
we will be very keen to listen to you today.
Yes,
Go
sir.
ahead, share your screen and go ahead.
Dr. Prakash, would you like me to share your case? I have your slides.
Just a minute.
Which do it, yeah.
Is it visible?
Yeah, we can see your screen.
Good evening, everyone. I'm Dr. Prakash Bhatt. It is very much, it is nice opportunity to present, to talk in front of Dr. Ichaporia sir. I'm thankful to him because we learned a lot from him, from the neuromeet and from the approach meet. I will talk on the management of the acute ischemic stroke. And there is a summary of 9 real life, that is a straightforward case of stroke thrombolysis as per guideline. But still, it is a small summary from the tier 3 city like Bhavnagar, at a small city of the India tier 3 city. Before
We
going to
want people
the
from small cities only to do it. There is
Thank you,
nothing
sir.
small and big. You have to do
Yes,
it.
sir.
And
Thank you,
we
sir.
want people from small cities to do more than what we are doing.
Yes, sir.
You know, these big cities, we have a lot of traffic problem and this problem and that problem, and patients are not coming in time. Smaller cities are doing better than bigger cities. So don't feel you are from small city. You are not from small city. You are doing great work. So please continue.
So today's learning objectives, the stroke is the one of the most common neurological emergency we see in our day-to-day practice. Stroke is a very vast topic, and neurology is learned stroke by stroke. And today we'll focus on the ischemic stroke and thrombolysis. So by definition, stroke is acute neurodeficit, which is vascular in origin, affecting cerebrum, spinal cord, and optic nerve, which should last more than 24 hours. Mainly to subtype ischemic stroke, hemorrhagic stroke. Out of ischemic stroke, if it is acute, then watch for the window. And now the window of period of the ischemic acute stroke is concept is changing from the time to tissue, and based on that, intravascular thrombolysis or endovascular therapy. Majority of our patient not comes under a window period, so but still we have to treat. If those are not stable, then admit in the neuro ICU, monitor ICP, sugar monitoring, BP monitoring, and other management part of the stroke. And if stable, then go for a risk factor workup, etiological workup, and secondary prevention of the stroke and rehabilitation. So those patients we can manage in the OPD easily. What the skills we require in the acute stroke management? Those first one is history and examination, which comes by practice. Acute stroke code proforma, which we can devise by ourselves. And this stroke code I got from the Sayadri Pune. My teachers, thanks to Dr. Dute, Dr. Hemansan, and all the in the stroke code, I learned that it is a code blue like system, which will be announced in the hospital. It is just like code blue. Okay, there is a stroke code. The ER department will be alert, and it will call to the radiologist, to the neurologist, to the ICU specialist, and all the departments will play their role as early as possible to reduce the window period, to reduce the door to needle time. Uh, Then in the emergency department, the medical officer and when the neurologist will calculate the NIHS score, that is a severity score, and another one is MRS, that is modified Rankin score, that is the disability score. Both we have to calculate before the thrombolysis, and so that we can quantify the effect of our treatment. Again, in the radiology, best if the last scene ls and last scene normal is well known, then we can do ct scan, and if it is not known, then we have to do other imaging like mri and ct perfusion. But in the case of acute ischemic stroke, we should look for early signs of stroke in ct or mri. A radiology will help us, an aspect score, that is alberta stroke protocol early ct scan score, will help before thrombolysis or EVT.
Yes, but just go back.
Yes.
Go back to that slide. Yeah,
Yes.
see, you take help from radiology colleagues, but as a neurologist, you must learn how to read the scan.
Yes, sir.
You can't depend on the radiologists because they take time to come, and even if we send it by telemedicine or by PAX system, it takes
Yes,
time
sir.
for them. So it's very important that the neurologist or the neurology resident goes to the console and sees it himself, and he can transmit that images to the radiologist or to the consultant. But it's very important now, otherwise you waste too much time. What we
Yes, sir.
want is time is of the essence, and
Yes.
therefore we must learn how to see CT scan, how to see MRI. MRI is little more difficult to see than CT scan. But CT scan can also give you a lot of information, and you must learn aspect score in that. You must learn how to see for hemorrhage. You must learn
Yes,
how
sir.
to see for blood vessels. You must do the
Yes.
CT angio. So it is the neurologist's responsibility for reading the scan. That
Yes.
that will give you low door to needle time. So you
Correct.
take their help. Of course, you take. There is no harm in taking help of anyone. You have to
Yes.
take help from as many people as possible, but you have to develop that competence. That is my message to all of
Yes,
you.
sir.
Very important. Yeah, continue.
As we all know, there is 1 in 6 people worldwide will have a stroke in their lifetime. The WHO stroke definition, as I have discussed earlier, overall it is the second or third most common cause of death in the world. Stroke continues to be major public health problem and more often disabling than the fatal. Stroke is the leading cause of severe neurological deficit and costing burden to the society. Two major subtype ischemic out.
Prakash, just go to
Yes,
your cases. See, this theory now everyone knows.
yes,
So
sir.
just go
Yes.
to your cases.
Sir, there is a total 9 cases, which for that I have used tenecteplase because the costing is lower side and convenient to thrombolyze. I have used tenecteplase. Uh, I haven't put each case differently, but I have summarized in the table, and then I have provided the summary or the demographic and risk factors and clinical presentation of that 9 cases. The first case, 42-year male, presented with the dysarthria, right-sided facial palsy, and upper limb weakness. We have calculated national NIHS score, which was 5. We have thrombolized with the 15 milligram tenecteplase within 3.5 hours, and our door to needle time was 45 minutes. Post thrombolysis, there was no ICH. Post discharge after 5 to 6 days, the NHS score reduced from 5 to 2, And at the end of 3 months, MRS, modified Rankin scale was 0, and which showed full recovery. I'll not go in the detail of each the clinical presentation and outcome. I'll summarize my demographic factors like so. Out of that 9 cases, the age distribution was 42 to 72 years. The mean age was 59 years. Out of them, 6 males and 3 females. The common comorbidities were hypertension in the 6 patient out of 9. Diabetes mellitus was in 5 patient. Dyslipidemia was seen in 3 out of 9 cases. Other cardiac disease like rheumatoid heart disease with status post BMI, but there was no atrial fibrillation or no LV clot in 1 patient. Rheumatic heart disease with atrial fibrillation in 1 patient, and ischemic heart disease with LV clot in 1 patient. The clinical presentation in stroke territory, commonly all the patients presented with the hemiparesis and limb weakness or limb weakness, dysarthria, aphasia, and facial palsy seen variably. And 1 patient was with vertigo and gait ataxia. So based on clinical and imaging, the territories were involved most commonly MCA territory uh, in the 7 out of 9 patients. M2, M3 stenosis and occlusion were seen in 3 patients. The MCA M1 occlusion seen in 2 patients, but those patients were refused endovascular therapy, and I have treated only with the IVT. ICA occlusion seen in 3 cases. Rare locations like posterior circulation, pica, and PCA territory infarct in cerebellum and thalamus in 1 patient. All the patients received a tenecteplase, as I told, because of cost is less and easy to give. The doses range from 15 milligram to 20 milligram based on the weight. The window period, all were thrombolized within the 4.5 hours, the golden window, and average window period across the 9 patient approximately 3 hours and 43 minutes. The our door to needle time was average 48.4 minutes, which meets the recommended targets.
What was your lowest and what was your highest door to needle time?
Which is mentioned here, the lowest was 35 minutes and the highest was 75 minutes because the major concern is consent, informed consent. Many people are thinking and taking time, sir.
Yeah, that is a common problem. Yeah, okay. So pretty good. Pretty good. Your door to needle times are good, but you can still make it lesser. You can make it below 30 minutes. You try. I'm sure you can do it. You've done very well as far as this is concerned, but still you can do better.
Is not major issue, but while I'm explaining complications like intestinal hemorrhage, and then they are starting call here and there what to do or not to do.
What?
So
No, speak
the
up, please.
complications like intracranial bleed, intracerebral bleed, the majority of the relatives are worried for that complication. Okay, if he will
Doctors
bleed,
are
then
also
what to
worried,
do?
no, yeah.
Yes, sir.
We are also worried. My relative is worried. We are also
Yes, sir.
worried. But that is part of the game.
Yes, sir. Yes, sir. Yes, sir.
Okay, Dr. Prasanna, do you have to say anything to these figures?
Yes, sir, definitely. Sir, I mean, even I have evolved in terms of, yeah, convincing relatives for thrombolysis, and nowadays the lesser we speak, the better it is, to be honest. I mean,
what?
The lesser we explain, the better it is. So
Ah.
I usually tell them that this is a neurological emergency. Time is brain. Every minute that we are wasting in decision process is going to cause the patient in terms of disability much worse. So
Exactly.
the onus will be on you, and there is a very minor risk of hemorrhage that is around 6%, and that's not really much. And when we weigh it against the benefits, it is much higher. So let's go for it. That's what I say. And I always say that do not worry about charges. We are giving the injection right now, because that's another factor people think of, especially in,
Yes.
in tier 3 city where there is some concern about the cost of the injection too. But then I tell them that this is just an experience. I said don't worry about the cost of the injection. That will take care later on. We are giving it right now. So once I'm bit of a when I explain it this way, I have rarely faced resistance. So the door to needle time in my hospital lowest has been 12 minutes. Um, and that is largely because of the lab thing, that BTCT and PTA takes a little time sometimes. So barring that,
Yes.
code stroke declaration and everybody running down, that works very well, sir. So I was just trying to correct the time required for consent by using appropriate language, and don't try and waste too much time in explaining a lot more details. God forbid, if there is some complication, we can always sit down and talk with them, and that's very rare. We all know that.
I think that is an excellent way to do, and
Yes.
really I appreciate that very much, Prasanna, because of course, time is very important, and because of that, you've been able to do even at 12 minutes.
Yeah.
So that's excellent. And see, this problem is there in India, because we have to take consent and all. But many Western countries, you don't have to take consent because it
Oh.
is level 1A evidence.
Mm-hmm.
So, when you talk to people from Europe and America, they say it is level 1A evidence. So, do
Mm-hmm.
you take consent for cardiac arrest?
Yeah, correct.
Do you take consent if a person is getting a convulsion?
Yeah,
Do you take consent if something is stuck in the throat and you have to remove it?
right.
Do you take consent if somebody is bleeding to death in an accident? You don't.
Yeah,
So these are all
Yes.
life threatening conditions. So, but in India, we want the consent to be taken.
right.
You know, by law, we have to take the consent.
Yeah,
But you see, don't waste too much time on that. And if you do this, and you see the scan quickly, you go with the patient to the scan console. You give the treatment there in the console
yeah,
itself. You are saving valuable minutes,
absolutely.
and each valuable minute is equal to, I give that example of one karvanda. The karvanda, that blackberry. uh,
Mm-hmm.
Yes.
each 10 minutes you save that much of the brain.
Wow.
So if you waste this thing, if you waste half an hour, so many karvandas are
Correct.
destroyed in the brain. So
Correct.
every minute, every 10 minutes you waste, uh, uh, you're damaging one jambul, say jambul size
Come.
brain every 10 minutes. So you waste 30 minutes, and three jambul size brain is gone forever. So
Yes.
you see, you can give this example.
Right.
You can give this example. And what Prasanna is doing is excellent. Yes. Yeah, occasionally hemorrhages occur. Yeah, they occur. It hurts us. It hurts the patient. Yes. But if you don't do it also, it will hurt the patient.
Yeah, very
So
true.
if you don't do it,
Yeah.
and this fear that if there is a hemorrhage, you will be taken to court and you will be sued. Up
Mm-hmm.
to now, nobody has been sued in the world. Forget India.
Wow.
Nobody has been sued in the world for hemorrhage after IV TPA. What
Mm-hmm.
have they been sued for? If you don't give the treatment, which is level 1A evidence, that
Mm-hmm.
is medical negligence.
Yeah.
That means patient has come where he's an eligible patient for IV thrombolysis and you have not thrombolized. So somebody can ask you, why the hell did you not thrombolize?
Right.
It is level 1A evidence. So those people who don't give will be can be penalized, not the ones who have given and some complication has occurred, because you have done it in good faith. It is level 1A evidence. It's accepted all over the world. So don't be fearful. Yeah, we are fearful. We are fearful, yes. Fear is an important part of life. You have to have little fear. You cannot be so foolhardy also. But don't get paralyzed by fear, please. Don't get paralyzed by fear. Okay.
Yeah.
I'm very interested to know what happened to those M1 occlusions. How did they do?
As
M1, and you said no, three patients had M1 occlusion.
yes, sir. As
I'm very
patient
interested
had.
to know what happened to those guys.
Yes, sir. Yes. Sir, initial stroke severity was ranged from 4 to 16.
Yeah.
Means mostly mild to moderate strokes are there. Five patients improved completely. And NIHS 0 to 2 at the discharge or at the end of 3 months. Two had NIHS score more than 4, but also but improved from the baseline. And one deteriorated. That case 9, NIHS rose to the 22 from 18 due to malignant infarct in the left side ICA, left side ACA, left side MCA, and left side PCA also, because PCA was fetal in origin. It was not deteriorated due to intracranial hemorrhage, but she was deteriorated due to re-infarct from the large LV clot, which we have done 2D echo on the next day. So that patient later on underwent for craniotomy, and she put on mechanical ventilation, developed ventilator associated pneumonia, and ultimately she succumbed to septic shock and died on the seventh day. So one patient of that MCA M1 occlusion, I had advised her for EVT. Initially, they were agree, because there was improvement of the after thrombolysis. There was a transient improvement after thrombolysis. NIHS deteriorated from 18 to 12. They were happy, but next day again in the reinfection, she became drowsy and unconscious. We repeated the imaging. There was a massive left hemispherical infarct. So that patient I lost because of she denied for EVT. And one more patient, that M1 occlusion, sir, he did not improve because he remained MRS is around 3, and he is still bedbound. He also denied for EVT. MRS, 5 patients were improved completely, MRS 0. One patient had MRS 1. Uh, Two patients had MRS 3 moderate disability, out of them that M1, and one more patient. And one patient MRS 6, she's died due to complications, other complication of stroke.
Yeah, but you see,
So, yes.
worldwide risk of death in stroke is 19 to 20%.
Yes, sir.
And yours in these cases is only 11%. So you have done very well. You have really done very well. And 56% have improved to MRS 0 to 1 or 1 to 2. 1 to 2, that is 56 plus 11, which is
Yes, sir.
66%, which is excellent.
Sir.
So many congratulations to you for
Thank you. Thank you,
aggressive
sir.
and good treatment. Of course, some people will die. I mean, M1 occlusion has 80% mortality.
Yes.
ICA occlusion also 80-90% mortality. So I think excellent work. Really, we are very happy to see these figures. Dr. Sase, you have been very quiet. Will you like to comment?
I would like to make 2-3 comments. As
Yeah.
one thing is that the aggressive door to needle time. I think that's one of the key to the success of these patients who are thrombolized. Second thing is that in our setups, in the the level, what we can call is the district level hospitals or tier 3 cities, the cost which was with Actilize was the main prohibitive factor. And I personally feel that this tenecteplase has brought down the cost. So acceptability in going ahead with thrombolysis is much better with tenecteplase as compared to Actilize. The incidence of a bleed post thrombolysis was much more with Actilize than tenecteplase. That's what is my personal experience in last 10 years ever since we aggressively started thrombolizing. So as you said, it's almost something like offering the best treatment for the stroke without even taking in consent and then explaining them the effects of it than the bad effects, I think would improve our success and the outcomes in these kind of patients. So for our level 3 cities, I think it's the cost and the consent which was prohibitive. I think a little more aggressively being able to thrombolize. Like when a scan is being done, the resident is with the mobile taking a video of the patient and sending it to me. So that saves a lot of time. Actually, I'm viewing the scan being done, sitting in my OPD, and the scan being done in the scan console room. So that is an additional factor. The communication has become better. So we are able to visualize the scan being done. So that will add to the earlier thrombolysis than the uh, radiologist reporting and then we waiting for them and two consoles. So that's why what I personally feel, and I um, congratulate Prakash for being able to do it in a place like Bhavnagar, and that's quite with a better outcomes.
Yes.
Appreciate.
Thank you, sir.
Yeah, your points are very valid, Dr. Sase. Cost factor is, of course, there. Another thing, which we can tell the relatives later on, maybe regarding the cost, okay, this is the most effective and most cost-effective treatment for stroke. There is an upfront cost in the beginning on day one, but then if you see long term, in fact, if the patient becomes mobile and can even go to the bathroom and look after himself, you are saving tremendous cost for the patient.
Yes, sir.
So maybe you cannot say this on day one or in the heat of the moment, but over a period of time, you can emphasize this. And as Prasanna says, no, that hardly anyone does not pay or refuses IV therapy. EVT, we have a problem. Yes, I have a major problem for
Yes.
EVT as regards cost. It is, but for IVT, very, very rarely, I can think of maybe one or two patients in thousands that who have refused IV therapy. So just give it, and actually by law, for an emergency case, you cannot refuse treatment. You should give it, and they do pay. They do pay. Costs are coming down, and you also emphasize to the patient that long-term cost for the patient, yes, upfront on day one is more, yes, agreed. But if you look over a period of 1 year or 2 years, or for the life of the patient, the cost is actually lower. See, it's a hidden cost. You can't calculate it. But if somebody is not doing well and in bed and all that, or dies, in fact, the cost is much higher.
Yeah,
So
an earning patient staying back
yeah.
because he is moribund, and then as against he joins his duty back within 2 months or 1.5 months, it itself will take
Yeah.
out the entire cost.
See,
And
it is
another
not
point,
it,
yeah,
it is not only earning patient. Even if it is a non-earning patient,
yeah,
somebody the caregiver has to stop his job, or
absolutely,
the woman has to look after the patient.
yeah,
And she may not be able to work, or she may not be able to look after the children so well if the grandfather has a problem. So actually, whether he is earning or not earning, family gets affected,
yeah,
and caregiver burden is tremendous. We should not discount caregiver burden. Caregivers also suffer
yeah,
tremendously,
yeah, yeah,
financially,
Definitely.
emotionally. They
absolutely,
get blood pressure, they get diabetes, they become sick, they cannot go out for a holiday, they cannot leave the person at home alone. So it produces a lot of emotional distress also.
yeah,
So across all ages, it is important, you know, whether he's 80, 90, 50, 40, 30, it doesn't matter.
yeah,
It is the cost of not treating is much higher than the cost of treating.
absolutely,
So,
Agreed.
maybe when you counsel, not maybe on day one, but a little later also,
yeah, yeah.
this point also you should emphasize to the
Beautiful,
patient
sir. Well
and the
said, well said.
family.
I'll definitely use it later on.
Yeah.
I just wanted to add one more point. I mean, because
Yeah.
we do so many thrombolysis, I have had three examples till date when a relative of a thrombolyzed patient brought another patient in
Yeah,
time.
yeah, yeah. Arey,
Yeah, yeah,
the
yeah.
word spreads
Huh,
like
yeah, yeah.
wildfire.
I mean, illiterate people being bringing people within window time was awesome, awesome.
Yes, yes, yes,
Yeah, yeah,
yes. So this is a very, very valid and very good point, that, the word spreads like wildfire. You do something good for somebody, 10 people will come to know.
yeah,
And 10 people get aware of stroke. Otherwise, they're not aware also of what stroke is. So you treat one guy properly, and the word spreads by word of mouth, and it spreads across like wildfire across the city or in that area, and many other people can benefit.
true.
So this point is also important, very important.
Another,
Thanks, Prasanna, for bringing it up. Yeah.
yeah, another point which comes
Yeah,
is most of the
Sase.
times
Yeah.
is that whether this is covered under the scheme. And I think
Ah,
we must put in the pressure to the government that this
this
needs to be
government
put.
not budging, man. They're
No, I
trying
think
this through this Ayushman Bharat.
yeah.
But they're not doing it only.
So that
They
would be
say they
another
want NGO
success
and
rate.
they want something. This Akluj group is doing through this Mahatma Phule or some MPKY. No, they're doing something through that. And but you have to do MRI, you have to do NGO, and it's a little complicated, but it is done. I mean, they are able to do it. We are not doing it, but they are able to do it. So it's possible, but we have to also impress on the government, and we have
That
to
is true.
push through our. We've been telling ISA to do this for last 5 years. Kya re Baba, tell the government this cost of IVT, bring it down, put it under Ayushman Bharat, put it under some scheme so that many people can benefit. But this PMC and all, they do pay, huh? PMC pays. PMC means Pune Municipal Corporation. Maybe other municipal corporations also can pay. We can do it through local bodies also. And, through that urban poor scheme and all that scheme, now we can do it. Something can be done. So what we are trying to say is just spread the net wide. More and more people should do.
That is true.
Prakash, please continue. We are just digressing because these are very important points, and our main aim is to see that this spreads far and wide. That is our main purpose. Yeah, so
Yes.
Prakash, please continue. Sorry to
So
interrupt
I
you
think,
so
sir,
often.
we have discussed all the positive and challenges, but still positive findings from this series. There was a high recovery rate. Almost 66% patient had excellent outcome. Uh, this was good protocol adherence group because currently I'm not going beyond the guidelines or beyond the some risky patients like risk of bleed. And we have only, well, after 4.5 hours, we have only MRI, diffusion, and flare mismatch group, that only. Those only I am thrombolizing with multiplex. And CT perfusion is just recently started in the city. So we'll try the tissue based window in some of the group after 4.5 hours of the stroke onset. But currently, this I have included only these standard 4.5 hours window group patients. Effective use of MRI and angiograph for the diagnosis and occlusion localization. So, thrombolysis with the tenective is proved effective in majority. Challenges were complication ICH in 2 patients, but in 1 patient there was only grade 1, that is the hemorrhagic infarct, HI1 only, so which was not that
Don't worry about
clinically
PH1.
significant.
Kuch
Yes.
nahi hota hai. Nothing happens. Don't only we are worried about PH2. PH1, HI1, HI2, don't worry. Kuch bhi nahi hota hai. Don't worry
Yes.
about it. Forget it.
Only one patient had
And if you do
PH2.
MRI now, you will always find small hemorrhagic dots. If you
Yes,
do
sir.
MRI after 24 hours, no, every patient you will find some hemosiderin or some hemorrhagic. Ignore it. It doesn't matter. If
Yes.
NIHSS has not dropped, it does not matter.
Yes. So one patient had that significant ICH and which led to MRS 3 in that patient. Again, that patient had M1 occlusion and one had fatality. That I have told that patient had LV clot, large LV clot, repeated embolism, and later on embolism she had massive left hemispherical infarct and uncal herniation. Later on, she died due to complication of ventilator-associated pneumonia and septic shock. Late thrombolysis, one patient I had thrombolyzed at 4 hours and 50 minutes. But again, there was a HI1, so which was not that significant. But many times after 4.5 hours, risk of bleed is high. Severe stroke and large vessels and multi-territory involvement had poor prognosis even with timely thrombolysis. Clinical insight, mild to moderate NIHS score had better outcome post thrombolysis. Early imaging plus faster door to needle time had better outcome as we have discussed. cautious use of thrombolysis in extensive, in fact, and multi territory involvement. Sir, here I have one question. If there is a MCA almost around one third to one and a half MCA, more than one third, in fact, as per guideline, it is a contraindication.
It is not
But
an
what is
infarct.
your
It is early ischemic change. See, infarct won't occur within 3 hours.
sir.
It is early ischemic change. Initially, it was a contraindication, but we are doing IVT and then EVT in these patients. So early ischemic change, or even in DWI, large area of DWI, this thing is now not a contraindication.
Okay.
So severe strokes with low aspect score is no longer a contraindication. It was previously, if you read old guidelines, they will say, but that is infarct, not early ischemic change. Okay. And what you have done, what you are doing is very correct. I always tell people that when you're starting, like in cricket, you hit the ball in the V. Don't try scoop and reverse sweep and uppercut and all. Don't try all those funny shots. Just hit in the B in the beginning. 30 cases. After that, you start your reverse sweep and paddle sweep and Dilshan scoop and whichever scoop hoop you want to do. But first 25 cases V ke andar maro boss.
Yes.
Then you will get confidence. Then you will become strong. You will get this thing. And then you can do all these funny strokes. Okay.
Yes.
So very well done, Prakash. I am very, very happy to see this. And please continue. And next time, present 100 cases.
Yes, sir.
Not
I'm
10, 100.
Yes.
Okay.
Online application which there is
Prasanna, what do you have to say? Prasanna,
Yeah.
say.
No,
Yes,
Prakash has done a wonderful job. I mean, great
application.
start, 9 cases, but with this outcome, he's beating the general world's trends actually already.
Yeah.
So I mean, he will pakka do better with better
you, sir.
reader time, especially where I'm sure he's going to work upon. He will do much better than
Of course.
Yeah, absolutely, no
No
problem.
doubt.
Yeah.
Sase?
Appreciate, as you said, I think initially he has to be careful and play in V, and then I think his numbers and he will approach to a century. He'll keep on hitting it harder.
Yeah.
Thank you, sir.
Okay. Thank you, Prakash. Well done. Keep going.
Thank you, sir.
Yes, Dr. Binak. You can share your screen.
Dr. Vinayak, are you facing any issue? You're muted. Dr. Vinayak, you are on.
Yeah. Yeah. Is my screen visible?
Not yet.
Okay.
Just below there is. Yeah. It's coming
Yeah.
up. Yeah, it's seen now.
Yeah. So good evening, sir, respected teachers and Prakash. Thank you for inviting me to Know Thrombus. I am Dr. Vinayak Jatale. I am a consultant at Aurangabad, Maharashtra. So the topic for my presentation is breaking the clock. So I have presenting 3 patients, and all 3 patients are beyond 4.5 hours. So beyond routine thrombolysis, and I am sharing some real world data. Okay, how we can actually justify that we are thrombolizing some patient beyond the routine conventional 4.5 hours. So to my public who are there listening and my teachers. So my purpose of presentation is, can we give more benefit to the stroke patients with respect to time window? And can we go beyond the horizon that we are seeing? The horizon is about 4.5 hours. And do we or can we go beyond that horizon is my purpose. A timeless trial which has been recently published says that 2/3 of the stroke patients come beyond 4.5 hours. So my purpose is to see that we can give maximum benefit to those patients also who come beyond 4.5. So coming to my case one, he's a 79-year-old male, hypertension, tobacco addiction, vegetarian. 2 years back, he had a transient ischemic attack, but he never took medication. He improved in within 24 hours. And 2 years later, now on 7th June, now only, he presented with night-sided weakness at 10 a.m. onset. So he presented to us at around 3 p.m. Onset to door was 5 hours. Clinically, he was conscious. He was partially following command. His BP was 150 on 90. Pulse was 90 per minute. His weight was 75. And his NHS was 16. Sensorium, speech, right arm, right leg, and sensation all involved to 16. Okay. So in a background of hypertension with following risk factors, tobacco, previous stroke, hypertension, I think we can see here there is dyslipidemia as well as he has elevated homocysteine and with the NH of 16. But the issue was 5 hours window. This was his imaging. Okay, as we can see, the putaminal hyperintensity seen on diffusion weighted images, but yeah. I can show here that the T2 images, there is slight hyperintensity, but not complete. So there was a subcortical infarct on diffusion weighted images, but the T2 flare images did not show presence of a complete stroke that has happened. So there was diffusion flare mismatch in my case. And as we can see in these angiographic images also, I hope this image is visible properly. I will show it again. So I can show it here that in T2, the infarct has not yet developed.
See it. Continue.
Yes, sir. Yes, sir.
Continue.
Yes, sir. And in angiographic images, we can see there are small vessel ischemic changes that are widespread. So diagnosis is acute ischemic stroke, there is a dyslipidemia, tobacco, hyperhomocystinemia, late MCAT, penetrating branches infarct with a right hemiparesis and NHS of 16. So she was still beyond 4.5 hours and there was a mismatch. So based on tissue imaging, we counseled the family member. We took a high-risk consent from them that we are going beyond the guidelines, and we lyse him with a regular dose of 0.2 mg per kg. For a 75 kg male, we did with 15 mg of 7.5 ml of 1080 place of 20 gram. So what was the outcome? Post-lysis NCCT was that there was no bleed, there was mild hypodensity in CT, and there was generalized cerebral atrophy. This is the image post-lysis, which shows that mild hypodensity along the putamen that I showed the tissue earlier, but there was no bleed. So we were able to confidently lyse this patient and prevent the bleeding, and we were able to document it. Now this is a radiological improvement that I have shown. Coming to clinical part, this is the patient on day 10 of illness. His NHS in previous 24 hours only improved from 16 to 12. And now his power was 0/0 in right upper limb, lower limb, and face. Lower limb mildly improved. It was 3/5 and lower limb. So in my case, upper limb power was not that much improved. It was 1/5 and facial was also present. So with sensorium, speech, and lower limb power that has improved, we were able to justify a thrombolysis that was beyond 4.5 hour based on the MRI based imaging. That is diffusion flare mismatch. There is some theory part which I want to discuss if you allow, sir. So what is the foundation with which we start the thrombolysis for 4.5 hours? That is the AHA guideline 2019, update of 2018. So this foundation says that in selected cases, up to 3 hours or up to 4.5 hours, we can go for thrombolysis as a routine thrombolysis. But question arises, now whenever we go for casualty and a patient comes at 5 hours, 6 hours, 7 hours, the technician or the RMOs call us that कि सर पेशेंट का विंडो निकल चुका है, अब मैं इसको आईसीयू भेजता हूँ, एमआरआई बाद में कर लेंगे. बट यूजुअली वी शुड गो फॉर a patient who come beyond 4.5 hours but less than 12 hours or 24 hours, we should immediately go for imaging and see if there is some mismatch and see if we can go for thrombolysis or give advantage to those patients. So I wanted to just see from where this data of 4.5 hours came. So I went back to 1992. There is a data 40 years back. This was the first publication for stroke thrombolysis in which they did was what is the time and what is the dose that is usually required for stroke thrombolysis. It was an open angiography based disease study in which they started from the minimal dose. They did the lysis. After lysis, 1 hour later, they will see whether there is a 70% improvement in canalization of the block, and they will decide the dose accordingly. So in every group, they used to increase the dose by 0.1%. So they found out that the M1 and M2 branches occlusion were more likely to undergo recanalization by 60 minutes, and there were hemorrhagic dose was 20 to 10%. How did they did was, in the first study, they used to start with a minimal dose of retiplase, that is 0.08 to 0.09 million international unit per kg, that is equivalent to altiplase of 1 mg per kg, 1, 2, 3, 4, and they came to point that 0.3 mg per kg is sufficient for stroke thrombolysis, and they also said that the maximum bleeding occurred at 6 hours. So they were able to rationalize that before 6 hours, we have a benefit of thrombolysis. This in 1992, this was followed by two major studies in which there was thrombolysis that was done within 90 minutes and within 180 minutes. And the dose was of altiplase, RTPA, 0.35 to 0.18. And they were able to justify that patient RTPA without risk is a potential benefit for RCT. And they were able to calculate the dose that 0.85 is the most beneficial dose for stroke thrombolysis. And even they proved that in animal studies, maximum bleeding occurred within 2 to 3 hours. So any stroke thrombolysis before 3 hours has less risk of stroke. That is how we came to 3 hours. This was followed by the landmark trial, that is the NINDS trial, in which a trial was done from 1991 to 1994, in which they proved that within 3 hours, altiplase can be given 0.9 mg per kg based on the previous studies. This was the result of NINDS. This was followed by the guidelines, 2007 guidelines, in which they give that the CT RTPA is used within 3 hours, 0.9 mg per kg, maximum of 90 mg within 3 hours of symptom onset. And favorable outcome in this was between 30 to 50%. This was followed by 2013. And this table shows what was the benefit of 2013 guidelines as compared to 2007. So 2013, we get to know that we can expand to 4.5 hours. This study was based on ECS SS studies 1 and 2. And in 2013, we were able to use MRI for stroke thrombolysis. And 2013 also emphasis on regional stroke center system and encourage MRI usage for CT selected cases and helping in clinical judgment of the patient. So how to go beyond the 4.5 hour window? We have these trials, Hermes, Extend, Wake Up, Diffuse, MR Witness and DOS. We choose MRI diffusion flare mismatch or CT perfusion mismatch for selecting patient who can benefit beyond 4.5 hours. So we have three major studies currently, which one is TRACE 3, second is Chalbis and Timeless. I have made a combined table for this. In this, the window that was used for stroke thrombolysis was 4.5 to 24. For Tracy, that was published in 1 year back, June 2024. Timeless in 2022, and Chalbis. The imaging that was used was perfusion-based studies, and they found out that the Tracy trial first aim was the patient who cannot undergo thrombectomy should get benefit from thrombolysis. That is the also the major aim of us also, that the patient who are not affording for thrombectomy within 24 hours can they get benefit by thrombolysis only. So their conclusion was the tenecteplase is effective at late window thrombolysis without TVT. Timeless trial had a neutral course, while Chaplis 2 T2 also showed a beneficial of thrombolysis in selected cases who show a mismatch on CT perfusion. This was the INSC slide, International Stroke Conference 2025, which says that in 4.5 hours with the basic imaging of CT, you can do a thrombolysis. 4.5 to 9, we can go for some advanced imaging. If we show some mismatch, we can go further for thrombolysis. So it also summarizes that there is an emerging evidence to the use of tenecteplase in extended window time beyond 4.5 hours, but still we are waiting for stage 3 and HOPE study result. So we have no firm evidence or firm guidelines to suggest further stroke thrombolysis, but we can select some cases for stroke thrombolysis beyond 4.5. So based on this, coming to my second image, this is a 56-year-old female. Pardon for this age. She is a 56 female. Previous day at 7 p.m. she had a difficulty in walking.
But one
lower
thing,
limb.
Vinayak, one
Yes, sir.
thing I want to say is you have to do for late window,
Sir.
you have to do detailed imaging as per these trials. That means you have to do CT
Yes.
perfusion.
Okay,
Now,
sir.
many centers cannot do CT perfusion properly. And,
Yes, sir. Right.
you know, even those centers who can do it, it may not be representative of penumbra. So first of all, it's difficult to do. Many radiologists don't know how to do it.
Yes, sir.
And it can be only done in very specialized centers. And even so, I'm not a great fan of the CT perfusion because of all these difficulties. And you know, we've been doing it in few patients, and we've been finding, oh my God, it's very difficult to interpret. Sometimes that MTT comes high, sometimes cerebral blood flow becomes this. So it becomes a little difficult to do. So
Sir.
I stopped doing.
Sir.
And no, really, I'm telling you what I'm doing. And we are not over strict on 4.5 hours. I mean, it's a guideline. Yes, I understand the trial has been done for 4.5. But don't be so over strict. I mean, if he comes at 5 hours, yeah, just give it. Yeah. Just
Yes.
give it, because to do CT perfusion and all, my God, it's one big headache. And at the end of it, you're more confused. And, we had bought that Rapid AI software for 22 lakhs, and it gave such crazy results that we said, Are Baba, thank you. Now we don't want to do it because, our decisions were changing in a negative way. Instead of helping us, it was creating more problem for us.
Confusion.
So I was very much upset with it, and I stopped doing it. And
Okay, sir.
I've been talking to many people. I mean, they are also not big fans of CT perfusion. Most people, I mean, some are doing it, of course. Yeah, and in the trial, it was done. All this timeless trial and trace 2 trial,
Yes.
CT perfusion was done. But I doubt very much how many people in India, maybe 2 or 3 centers can do it properly. I cannot do it. Our people, I'm sorry, even by using AI, we are facing a lot of difficulty. So I just disregard it. And if the infarct is small and patient is okay, I give IVT if EVT cannot be done. Cannot be done or patient refuses, we give IVT. and the risk of getting hemorrhage is slightly more, but it's not sky high. So, we were worried about hemorrhage and this and that, but it's not frighteningly high. So in selected cases, we do give it. This is my personal view. I
Yes,
mean,
sir.
it's not accepted by everyone. Yes, I agree. But these are the problems we have faced with this thing,
CTP.
with the CTP or MR perfusion also.
Yes.
Yeah, please
Sir,
continue.
I have a question on diffusion flare mismatch.
Huh?
Is it
Yeah,
purely
diffusion flare
subjective
is a
or
good surrogate
it is?
marker. Other thing you can use is ASL. ASL is a poor man's perfusion. So you can use that, and if you find that the area of perfusion is more than the infarct seen on DWI, maybe you can give it. So you can use ASL, or
Okay, sir.
you can use this. Of course, diffusion flare mismatch is a poor man's CTP.
CT.
So we can
Yes,
use
sir.
it. It's a good thing. And we have found that patients improve. They don't improve as well as 4.5 hours. Of course, they don't. But they improve better than if you don't give treatment.
Yes.
So it is not an ideal situation, but given the condition that we are in, and patients come late and this thing, so it is a good via media.
Sure. Sure, sir.
My question on the DWF flare mismatch, मतलब
Huh?
is there any objective criteria कि मतलब फ्लेयर में बिल्कुल नहीं दिख रहा है
That
या
is,
तो थोड़ा
see,
बहुत
in
दिख
the
रहा है तो
wake up trial, they use the criteria that flare you should not see anything. But now the question is that in the flare, if you see a little,
yes sir, in his
and
case
in diffusion it is more, so should you deny this patient? This point was not addressed in the trial, but that doesn't mean that you can't do it.
Yes.
So if you see a little here and there, I don't see any reason not to do it.
yes
I mean, see, the trial gave you that data. See, trials have to be successful, so they have to put very strict criteria.
Right. Yes.
That cannot sometimes be translated into real life situations.
yes
That is the issue. Okay, trial said this, wake up trial said nothing should be seen on flare. So therefore don't give. Are who said like that? If little bit is seen, little here and there is seen, of course you can give, yeah, come on. Then another trial will come after 5 years. Okay, the diffusion was 100 and flare was 50. So even those patients benefited. But these trials take time to come.
yes
Okay, so this is my personal view. Huh? This is not in literature. But
yes
if you look at it in the broad sense, it doesn't make sense.
yeah
Yeah,
Yes.
continue, please.
Yes, sir. My second case, she female, 56-year-old female. At 7 p.m., she had a difficulty in walking. She went to PHC. She had started developing vomiting and the weakness worsened of right side upper limb and lower limb. At 2 a.m., her upper limb became completely weak. And 5 a.m., she started showing seizure at a PHC that was 60 kilometers away from Aurangabad. So once started showing seizures, at 6 a.m. she reached at our center and she was in persistent focal seizures. So this was a stroke that was presenting a seizure. This was a MRI that was done in the morning. This shows a left ACA territory diffusion changes, left ACA territory. And on flare, there is a slight borderline changes on the ACA territory that I will show here also. And also on angiogram, you can see there. So the onset was 1 day ago, 7 p.m. and patient was worsening persistently throughout the night and presented to us at morning 6 a.m. to us. So presentation was 11 hours. There was mismatch present. There was no other absolute or relative contraindication. So in this case also, we took high risk consent from the patient that we are going beyond lysis and beyond the routine stroke protocol and doing a lysis. So with the routine dose of 0.2 mg per kg, we lysed her, and the NHS at presentation was 13, which include 7 first 24 hours, and her current NHS after 15 days was 3. This was her video on 15th day post thrombolysis.
Superb.
Great.
Dr. Sase,
Yeah. Can appreciate the change. Terrific.
Should I move to next, sir?
Prasanna is left.
No, 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 no. I'm there. I'm
Yes.
very much there.
Can't see you.
No, no, I'm there, sir.
Yeah,
Yes,
Yeah,
say
yeah,
something, Prasanna.
yeah. This is awesome. I mean, this is one case where I wouldn't have possibly thrombolized. I must salute him to take this decision. It's just too good, too good. When I see this result, it's awesome. You know, as you say, sir, we always learn. We always learn from these people. I mean, it's just great, just great,
Yeah.
outstanding.
Yes, sir.
I
Actually,
wouldn't
this
for
was
life, no doubt.
actually
Not even in dreams we would have thrombolized.
Yeah, no doubt about it. Yeah.
Sir, actually, this MRI images, they makes us dilemma. So should we lyse or not lyse? Because these changes that we see in T2 are not complete. So I really take a bold decision again, sir.
Yeah.
So ये
should I-
CTP, PTP is all bakwas.
Sir,
Okay, good. Chalo.
one
Yeah.
more case, sir.
Yeah, last
So
case.
this was a stroke mimic, sir.
Yeah.
This was a case of head injury. There was a 70-year-old male. He was chronic alcoholic. He was hypertensive, and he left medication 3 months ago. So at 10 p.m. a day before, he had taken a binge alcohol, and his cycle bumped into a roadside truck, and his left shoulder got injured. He was admitted as a case of head injury at the outskirts in Jalna. His NCCT was reported that they told that it was normal, but it was not. There was a small infarct in the right posterior aspect of the MC territory. He went home after 1 hour, and when he went home, his wife observed that there was a persistent left-sided weakness. He was not able to bear weight over his left leg, and he was not able to raise his left arm. So he said that his arm weakness is because of his injury, but why was the only weakness? As per wife, there was no fluctuation in weakness overnight. Next day, 5:30, he was a father of one of our staff, and he was in village. So next day, it was Sunday, and they came up to us at 5:30 p.m. the next day. MRI was done at 7 p.m. and dole to MRI was 22 hours. So this was the MRI patient, this was diffusion, and this is the flare images. We can see there was a small infarct that has developed over the flare images, and this the area of diffusion does not match with these T2 flare images.
We can't see it very clearly. Just tell us where is the infarct?
Yes, sir. In diffusion, yes, sir. These are the
MCA.
yes, sir.
Yeah.
This is the diffusion
Okay.
images. Left MCA territory, sir.
MCA.
This left MCA, there is a diffusion changes as compared to T2. There's a small infarct in the posterior aspect. That was also in the CT. That was done a day ago. But the stroke has worsened. This diffusion has worsened. But there was a clear mismatch in T2. Here also, going slightly up at the section of the midbrain, diffusion shows our hyperintensity. I hope this is visible. But there is no changes in T2 images, sir. I hope my images are clear.
Yeah.
Yeah, sir. And so this was a 70-year-old male, which shows a clear mismatch, T2 and flare. And he was way beyond conventional time. There was no other contraindication. He was hypertensive. He was not any medication. And he was not affordable for thrombectomy. So I again took a high-risk concern from this patient. So I was really in dilemma. It was 23 hours. There was a mismatch. To lyse or not to lyse was my really concern. So door to needle, 23 hours, we lysed him. There was no bleed. There was no doubt the infarct has established. There was no complication, and we discharged on door 9 with the NIHS, which decreased from 20 to 14, sir. This was his post-lyse CT, sir. We can see these are some ischemic changes.
Infarct is there, no doubt.
Infarct is there.
Yes, sir.
But he has improved. He cannot improve
Yes, sir.
completely. Impossible.
Yes, sir. Yes, sir. And this was his MRS after day 30, sir.
You know, he banged on the left side, probably he had hemianopia, and therefore he
Yes,
banged
sir.
his left shoulder. So
Yes, sir.
probably he had a stroke and he banged the stationary truck on the
Yes, sir.
left side. That is
Yes, sir.
because he had right hemianopia.
Amen.
Possibly. So maybe it has started before he banged the truck.
Yes, sir. That was
Maybe, I
all.
don't know, but
Yes.
it's possible.
Yes, sir. Because the CT that was done on the day of head injury also showed a small infarct in the paracoccipital region.
So it must have been there before, you know.
Yes, sir.
But excellent recovery, huh?
Yes, sir. Actually, we liaised him. He was one of our staff's father, took a high risk consent. My major concern going for lysis was the radiology, that there was a mismatch, which I was able to explain him that there is an ischemia, but in fact has not yet developed completely. We should go for, and no doubt most of the patients are not affordable for thrombectomy. So this was his outcome, sir.
Good. So Dr. Bhatt,
Yes.
Smith flare did show a small lesion, but it was not as big as the flare. So
Yes.
it was a partial mismatch.
Partial missing. Yeah.
So even then it worked. So, you know, the trial is done with that, but that doesn't mean you can't do it. Yeah. Don't
Yes.
be too over strict here with all these trials. That's what. And Vinayak, beautiful, huh? Beautiful.
Yeah.
And you've got good guts, huh?
Here one, yes, here one question at the 23rd hours, without collaterals, really this TNK is helped or there is a recovery? It is like that only.
Now we have given TNK now, so let us say that
Yes.
TNK has helped na yaar.
Yes,
Why
sir.
you want to say abhi diya hai na? Take the
Yes, sir.
credit na.
Yeah.
You don't get credit many times. You get
Yes.
many brickbats also. Take the credit.
Yes.
Why you don't want to take the credit?
23rd hours, really viable at this point without collaterals. And if collaterals are there, then
So see, you know, this large diffusion, what you see now, it may not be completely infarcted. There may be islands of viable tissue.
yes.
DWI, large infarct. You know, previously we used to say that whole thing is infarcted. Not necessary. Not necessary. You are seeing good improvement with large DWI lesions. You said
Yes.
no, that large
Yes.
infarct you will not thrombolize more than one third.
Yes.
ये तो
Yes.
2/3 है.
Yes.
But see, you
Yes.
thrombolize these. So what you see on diffusion may not be, you know, previously we used to think that diffusion is equal to infarct. No, 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 no. Not necessarily. There are islands where there is viable tissue. It may not necessarily mean full infarct. It may just mean that, you know, the sodium potassium ATP pump is not working. It's not yet infarcted. If you reverse the blood flow, it may improve. So don't go by these very strict criteria, because you see these wonderful examples. Vinayak, well done, huh?
Yeah.
Yes.
You've
Very
got
nice.
more
Yes.
guts than us.
Yeah. Yes.
Yes, Dr. Sase,
Yes.
what do you have
Yeah,
to say? Sase,
I
Prasanna?
I would quickly summarize, sir, that what we learned today is that if it is in window period, please go ahead with subtly explaining the relatives about the risk.
Yeah.
But if it is beyond the window period, explain, take a consent, and take a daring and do it. I think that's what I learned today. I
Yes.
think
Yes.
Yeah.
Prasanna?
For me, it was watching a cricket match, one batsman playing in V and other having switch hits, Dilshan scopes, and everything, and both of them, you know, executing the game in such a beautiful way, coming out winning. So I really congratulate both of you, Prakash and Vinayak.
Thank you,
You
sir.
both of you are awesome, and you really make us learn. You know, we never feel old when we see people like you. We feel young, we feel like student, thanks to people like you who are doing such a wonderful job.
Thank you. Thank you, sir.
Okay. Yeah, I think these comments were excellent from both the moderators. Excellent comments. I think we are running late.
Yeah.
Can we
Thank
wind
you.
up? Vinayak, anything more you want to say?
No, sir. No, sir.
A
It was
picture
just
speaks
that.
more than 1,000 words.
Yeah, sir. Yeah.
Okay. Chalo, let's wind up,
Thank you.
Pratiksha.
Thank you, sir. I guess we had a wonderful cases today, and as we have seen, we are learning new in every session. I guess there is always some new things to learn, which is very exciting and interesting stuff. So I'd like to thank Dr. Icha Puria first of all, and also the moderators and the speakers, especially to bring out such interesting cases. So thank you everyone, and thank you all the attendees who are there. Thank
Yes.
you everyone, and I guess we can have a good night.
Thank you.
How many
Bye-bye.
attendees?
Yes, I'm just getting that number. Just give me a minute, sir.
Hmm.
So it were 300.
300 is a good numbers.
Yeah.
So Prakash and Vinayak, 300 people know you
Thank
all
you,
over
sir.
India.
Thank you, sir.
Yes.
So well done. Well done, Prasanna and Nathaniel Sase. We had a very, very enjoyable time. Comments were excellent. And as usual, we learned a lot. So thank you, everyone. And good
Thank you, sir.
night and have a pleasant evening.
Thank you.
Thank you, sir.
Good night.
Thank you, sir. Thank you.
Thank you,
Good night, sir.
everyone. Good night.
Good night, sir.